Okay, do you want me to leave it on my share screen or you want to start here?
We can start here.
Okay.
Hi, everyone. I'm Kylie Hanish with Return to Zero. And before we get started, we're still waiting for people to join. I'd love to hear where you're calling in from or joining us from and what you do for your job that you work in maternal health care. And you can type that in the chat box. Yeah, if that wasn't clear, sorry. Hi, Catherine. Hi, Barbara. You cannot see the chat. Let me see what I can do about that. So the chat feature, if you go like underneath at the bottom of the screen, there should be a little chat box, and it might be under the more, with the three little dots. And you have to, when you say to, you have to choose all panelists and attendees that you're sending the message to, and that might help. So I got a lot of messages here. Whitney, hi Whitney, you're a perinatal social worker at a hospital in Portland. Welcome. And yeah, I'm just acknowledging the fires. I'm in Los Angeles, so is Dr. Millie. We're all on the West Coast dealing with lots of fires and smoke. Suzanne, you're in Bozeman, Montana. You're a director of a nonprofit focusing on perinatal mental health. Welcome, Suzanne. Carrie, you're also in Portland. You're the NICU Family Support Liaison at a children's hospital. Hi, Barbara. Again, you're in Chicago as your perinatal educator. Nanu, you're from Portland. A lot of people from Portland. Here's another person from Montana. Brenda, welcome. Ginny, you're at the NICU at Providence. I'm gonna guess you're in the LA area. Welcome, Colby and Cynthia. And Terry, you're in Seattle. Danielle, hi Danielle. You're in Illinois, in the Chicago area. Andrea's training to become a doula. Tasha, you're a nurse in Sacramento. Catherine, you're the pediatric ICU, part of the bereavement committee in Chicago. Okay, now I have way too many messages to catch up on. This is really, I have 30 new messages. I can't keep up with all of you, but yay, welcome. So good. We have wide representation, right, from across the country. That's really exciting. And we have someone from the UK that's joining us. Good. Hi, Birdie. Nice to see you. Okay, so good. You guys are, we have a wide range of people here, which is really exciting. I'm going to go ahead and just get started because I know that we have a lot to cover. And so I'm going to get started, just a little bit of an introduction of who I am and who Return to Zero is, and then I'm going to hand it over to Dr. Millie. So I'm Kylie Hanisch, and I'm the founder of Return to Zero Hope. It's a nonprofit focused on pregnancy and infant loss, largely in the mental health aspect of pregnancy and infant loss, but also I'm very much dedicated to helping increase confidence in providers working with families during the perinatal period to help them better support parents going through a loss. And so I had a stillbirth myself in 2005. My son Norbert was stillborn at 35 weeks due to a liver cyst that burst. And so this has kind of been my journey. It took me a long time to get here to be able to help other people, but I feel honored for Norbert's father, Sean, and we created the film Return to Zero, which is a feature film based on our personal experience with loss. And then out of that grew Return to Zero Hope. And so just as an organization, we do directly support parents. We also create communities online, and really we're really focused on bringing awareness to perinatal loss, also providing support, and as I said before, helping empower and create confidence in providers working with families in this period. So today's webinar, which is titled Reducing Racial Bias in Maternal Health Care, is part of our Grieving in the Black Community initiative. We know that the statistics in the Black community in the United States of maternal and infant mortality are quite disproportionate to Caucasians and other races. And so we are offering a series of webinars around this topic. There's 2 other webinars that are available for free on our website within this initiative, and then we have today. So I will send out a link to those when I send out the recording as well. So I'm going to stop here, and then I need to record this. So I'm going to introduce Dr. Millicent Rose. She will tell you a little bit about herself, but I just want to say thank you so much for being here, for speaking about this very important topic, but it's not an easy topic to talk about. And I'm excited that we can start having an open conversation about this, and that we can continue the conversation within this community. So thank you.
Perfect. Thank you for that, Kylie. So I'm going to get started by pulling up the slideshow, and then we will go from there. It will also give me a chance to kind of introduce myself as you guys are following along. So as Kylie mentioned, today's title that we're going to be looking over, Reducing Racial Bias in Maternal Health Care. Let me introduce myself. I am Dr. Millicent Rose. I have my doctorate of education in counseling psychology. I have my master's of clinical psychology with an emphasis in marriage and family therapy. I am specifically a trauma specialist. I have about 10 plus years experience treating patients from the mental health aspect of having traumatic experiences. I own and operate a private practice in Brentwood, California. I am also a professor of clinical psychology at Pepperdine University's Graduate School of Education and Psychology. I'm a mental health consultant and a public speaker. With my consultation, I specialize in workforce trainings. So like workshops, webinars, and in-person trainings with organizations. Some of the topics that I cover on behalf of organizations include trauma-informed care, trauma-sensitive communication, workplace stress management, reducing burnout, compassion fatigue. I also do vicarious trauma for first responders, confronting suicidality in healthcare, and then one of my personal favorites, which is implicit bias, and as we've extended it today, implicit racial bias. I'm also a curriculum developer and a program developer and evaluator, mainly for mental health programs. And then I also do a little bit of media psychology, which just really references I might be a psychologist on set or a therapist on set for when either documentarists or directors are going over traumatic scenes with actors and they're imposing harm upon those individuals. I'm the person that they normally have there to buffer in between some of the harm that could be caused by acting out certain scenes. So just explaining a little bit about how I landed on this. I'm also a mother and a wife. I'm a mother to two very beautiful boys, one 5-year-old boy named London who is living. And then I experienced a stillbirth at 8 months of pregnancy. My son Leighton suffered a stroke in utero, and we delivered him sleeping at 32 weeks. Prior to my experience of having a stillbirth, I encountered a lot of trauma when I would discuss my birth experience or my birth story with other mothers. And I started to realize like there is this entire community of individuals who just by proximity of childbirth are coming out with high levels of trauma. And I decided that I wanted to make it a passion project and a research interest to get into maternal health care to find a way to support the entire perinatal community as it relates specifically to trauma, PTSD, and post-traumatic growth for individuals who had traumatic experiences throughout their childbirth narrative. And then just, like I said, also as a way of contributing back and relating back to the experience of losing my son. So let's get started. As you are attending today, what are some of the learning objectives that we have in mind for you? So as participants, you should be able to gain knowledge on implicit racial bias and how implicit racial bias operates. You will also be able to understand the negative impact that implicit racial bias has on maternal health care outcomes for women of color. But as Kylie mentioned, we're really going to have a primary focus on African American women. And then you should be able to proficiently discuss multi-level prevention and intervention strategies that should at least help to reduce implicit racial bias within maternal health care. As I'm going forward, I just totally forgot to mention, because what's going to happen is everyone's going to get distracted by my accent. So I'm originally from England, for anyone who's curious and they're trying to figure, is she Australian? Is she South African? What's going on with her accent? I was raised in England. I was born in Zimbabwe. I've been in the United States for the better half of some 15, almost going 16 years. So especially when I'm reading automatically, my accent might come out a little thicker. It really just depends on what I'm doing. So let's get started. To start off, I'm going to introduce you all with an activity that I do with my students. And this is just a good way to kind of introduce what implicit racial bias can look like in our day-to-day. So I'm going to pose this scenario to you. You've just bumped into your neighbor who identifies as white or Caucasian. She looks disheveled and worn out. She recounts that over the weekend, she took her dog walking in the park. While there, she saw what appeared to be a young African-American teenager tugging on a bike chain that was being used to lock a bicycle in place. Instinctively, she assumed that the young boy was trying to steal the bicycle, and she called the police. When the police arrived, a struggle ensued, and they ended up using a taser gun on the young boy to restrain him. The voltage of the taser was set too high, and as a result, the young boy went into shock and is currently in a coma at a local hospital. The police later revealed that the bike and bike lock did in fact belong to the young boy, but it was jammed, which is why he was trying to tug at it. The boy in question was found to only be 13 years old, despite his tall 6-foot frame. Your neighbor is emphatically pleading to you and claiming that she is not racist, okay? So I have some questions for you just based off of this scenario, and you can put these in the chat box. What are some of your transparent thoughts, your immediate thoughts, having described this scenario and you envisioning that this is what your neighbor has just told you has happened to them? What do you think about her actions, the things that she's done? How do you identify with the neighbor, the young boy, maybe even the police officers? And then I think the most important question that I want you to think about answering is your neighbor racist? Do you see her as racist? So if you can, just add some of your responses to the chat box. And I'll tell you, I've been doing this exercise for 4+ years with different students, different cultural backgrounds. And normally what people will say is, well, I don't have enough information to make a judgment about whether or not this individual is racist, which is very true. You've just gotten a snapshot. But the reality is, the way in which our brains operate and we process, we tend to make judgments very often without full information either way. So whether or not you want to, chances are you've already made a decision about how you're viewing this individual. So do you see her as racist? I'm going to take a look at some of these responses. Okay. Okay, some people said yes, I'm seeing her, my neighbor, as racist. Some people are like, no, this is implicit bias, and that she's biased. Okay, so there's someone else who said that while she doesn't see herself as racist, she has definitely engaged in some racist acts. And we're thinking about her discomfort and whatever occurred. And some people think she's racist, but she's oblivious to it. Perfect. Her biases tend to be racialism. Okay. All right. Great responses. So I'm going to tell you a little bit more about the preface for this activity or this vignette. This comes, I think it's a derivative from that social experiment and show titled, What Would You Do? For anyone who's seen What Would You Do? Why this is one of my favorite social experiments that show has ever done is because it's been recreated multiple times and still come out with the same results. So specifically, I'll explain to you the experiment that they've done. There was a park in Upper Manhattan, so a very affluent area, where a bike was locked in place, and they started off with 3 different teenagers that they were going to use to come and try and steal this bike. So each of the actors are instructed that if anybody asks them what they're doing, that they have to be clear in stating, yes, this bike has been here for 2 weeks, I'm trying to steal it, the owner hasn't come to claim it, so therefore it's mine, and then we pay attention to the responses. So the first scenario was with an African-American teenager. As he started trying to break the bike lock, he was asked the question, what are you doing? People came up to him, inquired, and they would ask, is that yours? And he'd say, no, it doesn't belong to me, but it's been here for 2 weeks. No one's come to claim it, therefore it's mine. So some of the responses that we saw from patrons who were just walking in the park or in that area, it really turned into a very quick mob mentality. And like I said, this experiment has been recreated multiple times. Where people would hover around him. I envisioned pitchforks. There weren't pitchforks. But they were calling the police. They were talking about restraining him, holding on to him, don't let him go. But it turned to a large crowd and a large gathering that was extremely aggressive towards the African-American teenager. When they were asked and addressed why they responded in that way, I think their argument was, well, if it had been a white teenager, I would have done the exact same thing. Wrong is wrong. So that pursuit of moralistic justice kind of came into play in that situation and identifying it in that way. Well, the next experiment happens a few days later, and this time we have a white teenage boy who's doing the same thing. A few people come up to him asking, what is he doing? He's articulate and saying, I'm stealing this bike. It's been here for 2 weeks. And I basically believe it belongs to me. A few people told him, don't do that. That's not the right thing to do. But most people walked away. I believe the police were called once in one of the experiments, but the other 2 or 3 times it was replicated, nobody called the police. So for the most part, people walked away. And when they were asked, why didn't you intervene? They said, oh, it's just a young boy stealing a bike. Things happen. It's not fair to call the police on him, right? And then the very last participant is a white Caucasian young teenage girl who goes on to do the same thing. She tries to break the bike lock. People ask, what are you doing? She responds, I'm stealing it. It's been here for 2 weeks. The owner hasn't come. Can anybody guess how the patrons responded? And you can put it in the chat box really quick. Perfect, so somebody said it there. They helped her. Yeah, they helped her. Which I think is a wonderful depiction of how implicit racial bias can really show up, in the sense that what we're seeing from the patrons who may have addressed the young African-American boy is the fact that this is an unconscious awareness as to what it is that is motivating their behaviors and allowing them to engage in acts that can be seen as prejudicial and race-based, and then obviously operating from a place of bias as well. Thank you guys for participating in that activity. So let's take a look at some really quick terminologies, because I'm going to be throwing these all around. I want to make sure that we're all on the same page as to what we're talking about when we talk about race. So our race is going to be defined as something that's associated with our biology. It's normally linked to physical characteristics like our skin color, hair texture. And then when we speak of ethnicity, we're going to be thinking about things that are linked with cultural expression and identification. The difference between prejudice, bias, racism. Prejudice is going to be an adverse judgment or opinion that we form beforehand. It's normally like a preconceived feeling, which can be positive or negative. And then prejudice, similar to bias, can also operate in a way that it creates an affective feeling that we have towards an individual or a group based solely on their group membership. In differentiating from bias, there's a lot of overlap between bias and prejudice, which is where people can get confused, but I think it's important just to note that the overlap is there for a reason. So with bias, you normally have prejudice involved, because bias is going to be an inclination towards a preferred group of individuals, a predisposition of, or a preference for a particular group, and then also thinking that bias is prejudice in favor or against one thing or person or group when we compare it to another. So that preference really tends to show up. And then separating ourselves from racism, because I know some people had identified in that scenario prior to that what we were looking at was a racist actor. Racism is really going to be defined as that belief that the different races possess like different characteristics that allow us to infer that one race is going to be superior or inferior in comparison to another. So while racism, similar to bias, also includes prejudice, it also includes discrimination, antagonism, and specifically thinking about members of a particular racial or ethnic group. So in order to understand implicit racial bias, let's take a look at what implicit bias is, which is obviously our basic foundation for implicit racial bias. To get started, what I want to first off start off by saying is we all have implicit biases. Every single person that is here has implicit biases. Why? Because they are derivative of our biological predisposition and innate desire to survive. Our biases allow us to assert prejudice, especially in the face of what we identify like predators, ways of keeping our offspring safe. So we all make quick, automatic, unconscious decisions that affect our behaviors, actions, and perceptions in order to keep ourselves safe, right? So that's our implicit biases. So specifically, we think of implicit bias as referring to like unconscious attitudes, stereotypes, and beliefs. And like I said, they're going to affect our behaviors, our perceptions, and then our decision-making processes. Implicit bias as a general umbrella term is going to apply to a multitude of different categories, including race, gender, age, sexual orientation, gender identity, but even think about something as simplistic as body size, right? We will apply implicit biases or biases based off of body size. I think the best description that I've ever heard for what implicit bias is what we don't think. So it's not the things that we have in assertion, i.e. identifying myself as being racially prejudiced, or a conscious awareness that this is how my mind operates and that I have a preference from one group to another. It's something that happens, it's unintentional, it's normally outside of our control, and it's normally activated involuntarily. It can be positive or negative, and then what we really want to pay attention to is that implicit bias at its core foundation can create some real world barriers to both equity, opportunity, and then as we're talking about maternal health care, any access that individuals are able to gain to quality patient care. So implicit racial bias, really kind of getting to the crux of it, is going to refer to our unconscious negative evaluations of a person based on the irrelevant characteristic of their race. Okay, so with implicit racial bias or racial bias, it does not require the presence of a racist actor or ideologies. What does that mean? So thinking back to that neighbor that you had that was emphatic in stating that she was not racist, we really would put her under the category term of implicitly racially biased. Only in the sense that if an individual does not identify with racist acts, behaviors, ideologies, albeit that they are motivated by prejudice and biases, they can still be qualified with racial bias, but they are not considered racist. One of the things that we're also very assertive of when we're thinking about racism at its highest form is that most individuals who identify with racist ideologies tend to assert that they are racist and they see themselves as superior to another person. More often than not, we see accusations against individuals that imply that they're racist. And when the person says, no, I'm not racist, my thing is I like to bring it in, well, is there a possibility that you may be racially biased, right? And then we also want to think about the fact that racial bias in its implicit form is normally formulated and heavily influenced by negative information received in childhood. So I want you to think of a white and or Caucasian individual who may have had little to no exposure of diverse communities, and any of the information or exposure that they have had since childhood has come in the form of negative imagery, notations, exposures, conversations, starting from childhood up until adulthood, which then leads them as an adult to unfounded negative attitudes about African Americans or people of color, albeit they have never actually experienced any of those things that they're thinking. So ideas like people are lazy, that they're loud, they're aggressive, they're uneducated. Some of these underpinnings or these thoughts tend to start in childhood, and a person is extremely unaware of how it has continued to influence their perception and interaction with other cultures and community. We also think of implicit racial bias as being an underpinning for poor racialized outcomes and structural inequality among African Americans within multiple settings. So we're also thinking like education. African Americans may not necessarily test with the highest scores, but research for years has always shown that, that there are racial biases that play a part in the fact that we just do not respond well to testing the same way that other communities do. In healthcare, criminal justice system, employment, socioeconomic status. Going back to the criminal justice system, I always like to point out, thinking about the fact that the criminal justice population and those who come in contact with the criminal justice system tends to recognize African Americans specifically as consuming somewhere between 50 to 60% of that population, but being mindful that technically speaking, we are still 13% of that population. That is a disproportionate amount. And which is why we start thinking about the way in which there are other players involved in the racialized outcome and this idea of structural inequality. So let's talk about what implicit racial bias looks like. And I think this is so important for providers to know what does it look like even from your perspective as the provider, but also for patients in their position. What does it feel like to experience implicit racial bias? Just to let you know, it has a lot of the same over and undertones as experiencing racism and prejudice. So we see it as something that can be subtly implicit or overtly explicit. So verbal and non-verbal behaviors. Thinking about sitting in a room, talking to your healthcare provider, and they're not even making eye contact with you. They're talking to another person in the room about you, but acting like you're not there. They're saying things to you, but they have their back turned to you. So we identify some of those behaviors as looking like being dismissive, minimizing, so reporting like something is going on with me, I'm having a symptom, and you're like, and the healthcare provider is just like, no, that's not happening, that's probably nothing, don't worry about it. It can also show up in the form of invalidating behaviors. Because it is implicit racial bias, it does come from a person of a different race. And then what we know is that it can result in complaints of racism and prejudice, which I think is so important to highlight because within maternal health care or within the healthcare field, what happens is the conversation of implicit racial bias gets caught or it gets lost in the cycle and the accusations of racism and prejudice. Being able to decipher between what may be a racial bias versus what is actually a racist and intended prejudicial act towards a patient or on behalf of a provider allows us to maintain the conversation and not place people in positions of defensiveness. If we can bring down the defensive barriers to say, okay, there may be some biases at play here, because like I mentioned prior to, we all have biases. It allows the conversation to evolve and for us to start looking at ways of confronting and combating racial bias. Okay, so from the perspective of either the patient or the provider, what does implicit racial bias feel like? Once again, for African Americans, communities of color, they may be more familiar with some of these feelings as they tend to cross over and double up with what it feels like when someone is prejudiced and or racist towards you. So implicit racial bias can feel like feeling unseen and unheard, feeling ignored, stereotypes judged without cause, belittled, feeling invisible. And then once you've had the melting pot of all of these feelings placed in one place, you are then going to question if your race is the cause of that negative experience. So I come from the discipline of psychology and the mental health field, and for diagnostic practices, the way in which we assert a diagnosis is with this rule, or what we refer to as like rule in, rule out, right? If I can't rule in a diagnosis, I have to rule it out. If I can't rule out a diagnosis, I have to rule it in until I can rule it out. Well, I want you to know that for people of color, African Americans specifically, we have to operate in the same way when it comes to prejudicial behaviors or things that we feel are coming from a place that is biased towards us. I have to rule in my race as a factor for someone's behavior towards me until I am in a position to automatically rule it out. And until that information comes, I have to keep it in my bevy, in my awareness. It's a part of my distinguishment in my efforts to keep myself safe, but also to understand exactly what it is that is at play here. So we're going to talk a little bit about the African American maternal and infant mortality rates. As Kylie had mentioned prior to, this is a part of a series for the African American and the Black community. That being said, I want to be mindful to say that we are in no way undermining or deviating away from the fact that the mortality rate does influence multiple communities, including other communities of color, as well as the African American community. But we're just going to focus on some of the statistics because this is where we see the highest disproportionate rate of statistics that is adversely affecting one community. So thinking about the maternal mortality rate, I guess I would just start off by saying the simple fact that everybody is here today, I think really brings us into the consensus that we know that in the United States, we are currently in a maternal mortality healthcare crisis, is how I would really describe it. On average, it's estimated that about 50,000 women experience life-threatening complications every year. American women have the greatest risk of dying from pregnancy complications among 11 high-income countries. I want you to also remind yourselves we're obviously operating in a first world country that is also recognized as the leader of the free world, but we rank with the greatest risk of dying and pregnancy complications. Within those statistics, the African-American women are 3 to 4 times more likely to die in childbirth, regardless of education, income, and any other socioeconomic factor. So just to be mindful, as I'm sitting here today and I am presenting this topic to you, as an African-American professor with a terminal degree, educated, of a pretty decent socioeconomic status, I am still more likely to die during childbirth than any other intersectionality of women in this entire country, which is extremely disparaging. African-American women in the US actually die at the same rate as women in Mexico and Uzbekistan. And then, like I mentioned before, the US is currently in a maternal mortality crisis that disproportionately affects African-American women. So we recognize that there is a disparity, and we highlight that while African-American women are more likely to die, this demographic also extends or is followed by Native American women, who are then right behind African-American women, Asian and Pacific Islanders, then white and Caucasian women, and then last was Hispanic women, and that was in the CDC's most recent publishing of the mortality rates in the United States. So I'm just going to throw this out there really quick, albeit I don't have the imagery for this. What I just said in there was that white and Caucasian women are more likely or are more likely to die during childbirth than Hispanic women, okay? So I'm going to break that statistic down a little bit, because sometimes when I see things and I'm just like, based off of my experiences in talking to the bevy of students that I have, patients that I've had, and interactions that I've had, I found that a little difficult to believe. So I wanted to do a little bit more research and to find out why it is that white Caucasian women are more likely to die during childbirth than Hispanic women. So here's what I found out. The CDC, first and foremost, in their collection of data on race, identifies women of different ethnicities that fall into the category of white and or Caucasian. So specifically, I'm going to say if you are Middle Eastern, you're classified as white and or Caucasian. If you are of a different ethnicity or a cultural background, i.e. European women who've moved from places like Russia, Sweden, who live now here in the United States, you are considered in that category. If you are from Syria and you wear a hijab, you are considered under that category. So when we're looking at the statistic for white and Caucasian women who are considered more likely to die during childbirth than Hispanic women, I think that there's actually a disparity there based off of the fact that we're not including the variation of white and or Caucasian women who have different ethnic identities, religious affiliations, and overt identifiers that can increase their experiences of biases. If we did more studies to find out and separate that little subsection of individuals who are qualified by the CDC as white and or Caucasian, I think that the number of white and Caucasian individuals who are suffering at the maternal mortality rate would actually be less than the number that we have verified for Hispanic women. I don't know that to be true. It's just based off of the research that I've done. But like I said, it is one of the things to think about in terms of how we're collecting data and what that implies. So maternal mortality rate, I'm going to give you, I really think it's important for us to put some faces and some names to what we're talking about when we're thinking about the mortality rate. First and foremost, I just want to state that the maternal mortality rate, as the CDC defines it, is considered death that occurs within the first year after childbirth due to pregnancy-related complications. So it's anywhere in that first year due to pregnancy-related complications. So I have three individuals here that I'd like to introduce you to. The first lady on the left, her name is Amber Rose Isaac. Earlier on this year in 2020, Amber Rose Isaac was pregnant with her first child, and she began to make some very public posts and tweets regarding her maternal healthcare experience, specifically stating she had low blood platelets in her counts, and she didn't feel like she was receiving enough investigation, enough preventative measures, and that her prenatal care and the quality of care was extremely poor. Specifically, she went online to predict that she was going to die during childbirth. And I am extremely sad to say that she was correct. And she did die during childbirth, a healthy, educated graduate student located in New York, having predicted her death, and unfortunately it coming true. The woman in the center that we have there, more of you may be able to recognize her, Serena Williams, probably one of the most famous tennis players, athletes. She ranks high in athletic intelligence. She's of high socioeconomic status, and then fame and notoriety. In an interview that she did with Vogue magazine, she basically revealed that she was a near-miss survivor. So having had a history of pulmonary embolisms, she had an emergency C-section to give birth to her first child. And she started seeing that she was having symptoms after her C-section that mirrored previous experiences of the other time she'd had pulmonary embolism. She had to advocate because her healthcare providers did not believe her. She knew herself, she knew her body, she got loud and proud about it, and eventually they were able to give her medical intervention, which is actually what saved her life. And just keeping in mind, she was actually right at the time. And then the last lady that we have here on the right is Kira Johnson. Kira Johnson died a few years ago during a routine C-section and scheduled C-section for what would have been her second child. She had complications and symptoms of internal bleeding. She was left in the surgical theater unattended without medical intervention for, I think it was several plus hours. And by the time that they did finally come in to intervene, she ultimately ended up dying. Once again, somebody who was in excellent health, educated, high socioeconomic status, ended up losing her life because of the poor quality care that she received. So we're going to talk really quickly about infant mortality rate, and just in thinking, because there have been a few articles that have been circulating, social media, news outlets about a recent study that was published by George Mason University that captured data from 1.8 million hospital births in Florida between 92 and 2015. And basically what that study revealed is that African-American newborns are 3 times more likely than white babies to die when they are looked after by white doctors as opposed to African-American doctors, which is a very disparaging statistic to even have to take into consideration. And then also being mindful that African-American infants have 2 to 3 times the infant mortality rate as white infants. And interestingly enough, we're talking about mortality rate. The mortality rate, the maternal mortality rate, so for mothers, is unfortunately increasing, while the infant mortality rate in the United States has begun to decrease, with the exception of African-American infants who, regardless of the reduction, are still twice as likely to die than their counterparts. And then we're also mindful to know that African-American infants have higher rates of preterm births and then low birth weights, which we can attribute to multiple different factors. But the thing that we're really going to pay attention to is just even the presence of some of these statistics. So let's take a look at some contributing factors here in the United States that could be playing a role in the maternal and infant mortality rate. So we know that there's a greater prevalence of maternal health care risk factors, especially when we're thinking about communities of color. So that includes socioeconomic status, education, prenatal care, physical health, mental health. So I stopped there on education really quick as something that we want to consider with maternal health care risk factors in thinking about African American women. And I want you to know that there have been studies that have been done that have controlled for socioeconomic status, education, prenatal care, physical health, mental health. And regardless of when those studies controlled for all of those healthcare risk factors or reasons, African American women were still 3 times as likely to die than any of their other counterparts. So going back to education, here's what I would say about African American women as a community and as a whole. African American women actually account for the highest rate of college enrollment, and I think we have accounted for that for the past 10 years. So in excess of any other demographic, male and or female, culture, race, ethnicity, African American women, specifically for the past 5 years, have continuously been identified as the most educated group in the United States. That being said, we are still the most likely to die during childbirth. And when we look at maternal health care risk factors, including education, that's one of the things that's normally posed. So we definitely want to think about ways of dispelling some of those myths. Our country as a whole in the United States has higher rates of cesarean sections. We have higher rates of elective surgeries in general. As somebody who is originally from a different country or from England, that's something that is kind of considered interesting when you look at it from the perspective of a country who doesn't prioritize elective surgeries or cesarean sections. And then we think about the role in which individual and systemic implicit racial bias contributes to some of the statistics that we heard prior to. We have a very fractured and unequal healthcare system. We have gaps in health workforce training. There's restricted access to quality maternal health care. And then just to add this on top of everything else, we have higher rates of mistrust among African Americans when it comes to the healthcare system. Not just for the sake of it, but in thinking about the United States history of using African Americans for experimentations or for experiments without their consent, without their knowledge, their participation, to the point of performing surgeries on African American women without giving them anesthesia, based off of the belief that people of color, African American women, are able to endure pain at higher rates than other human beings. So we know that that has trickled down itself and is another form of something implicit that the African American community has adopted, where we see it in previous generations and even along the way in current generations, where people just do not trust their healthcare providers. So that idea of mistrust plays as a contributing factor. And then poor patient education on maternal health and self-advocacy. Okay, so let's get to the crux of this and really just kind of discussing implicit racial bias in maternal health care and what are the things that we can do on a multi-level to reduce implicit racial bias. And we're going to take this from the perspective of patients. What are the things that patients can do, providers, and organizations? So in summary to some of the previous slides, here are a few things that I think is important for us to keep in mind when we're thinking about implicit racial biases relationship to maternal health care. Implicit racial bias has a negative relationship with quality maternal health care. All that really means is that the more there's a presence of racial bias, the less likely an individual is to receive quality maternal health care, which means if it's there, it's going to be really difficult for whether it's the provider or the patient to receive or to participate in exchange of quality maternal health care. Racial bias also has a strong positive relationship with poor healthcare outcomes, especially for African Americans. So we're also thinking about the ways in which we can actively reduce implicit racial bias, and we tend to do that by what we refer to as de-biasing strategies. And with our de-biasing strategies, we want to make sure that we're addressing measures that account for prevention as well as intervention. So what I can do to make sure that implicit racial bias doesn't show up. But when it does show up, how do I intervene? How do I counteract? And how do I work through it? Okay. So to start off, I'm going to discuss some of the things that patients can do in assistance. And I think it's important for us as providers to know and to also be informed about the ways in which patients can contribute. One of the biggest problems that we may have with our fractured healthcare system is that sometimes there is very little information, communication, and accountability from all the different varying levels when we think about the patient level, the provider level, and then the organizational, which is the systemic level. If people don't know what other people should be doing and should be held accountable for or could be doing to advocate and how we can assist them in their roles, it creates a breakdown in communication, and that's where we see the gaps in which now we're confronting this maternal mortality healthcare crisis. So what are the things that we want patients to take into consideration? We want them to think about educating themselves on navigating their healthcare systems. As somebody who came from a national healthcare system in the United Kingdom, navigating it was not really something I had to figure out how to do because it's kind of figured out for you to a certain degree. When I moved out here to the United States, I had to learn how to navigate my healthcare system for multitudes of reasons, but mainly because I didn't want to leave myself in a position of vulnerability. So just even understanding that first and foremost, we are in a mortality healthcare crisis that disproportionately is going to affect patients of color. We want to make sure that they are trying or at least initiating and having conversations to educate themselves on how to navigate that healthcare system. I highly recommend that patients partner with maternal health advocacy groups. A lot of the times, and this has just been in my discussions with other African-American women, I am a part of a few different groups where we discuss maternal health care outcomes. As African-American women, we share our birth stories. And the reality is a lot of us don't even know how to advocate for ourselves. And I don't necessarily think it's your responsibility. It has to be your responsibility to learn everything about advocacy, which is why we can partner up with maternal health advocacy groups who will do some of the advocating for us or just make sure that we're in the know-how. How do I advocate during my first trimester, second trimester? How do I advocate during postpartum as well? I think it's so important for patients who have fears and concerns to talk to providers about racial bias, especially if you've had previous race-related experiences with other providers. Ask your providers, what are you doing to address implicit racial bias and to make sure it doesn't show up in my prenatal and my postpartum experience? What are the things that you're doing to hold your office accountable? What are the things that you are doing together in organizations? Are you doing training? What do you know about racial bias? And how do you intend to protect me as a woman of color, African American or other, as I go through my birthing process? I think it's so important for African American women and, like I said, just the general community of color to make their mental health a priority. Here's the reality. The pink elephant in the room has been revealed, and we all know that as an African American woman, you are more likely to die just by proxy of being pregnant and wanting to give birth to your child. That alone and that simple information is bound to evoke, although you may not qualify for the full diagnosis, but it is bound to evoke symptoms of anxiety, depression. If you have previous diagnoses, we know that it can trigger previous diagnoses related to trauma. It can trigger personality disorders, mood disorders. There's just a bevy of list of things that could come into play. So if you are in the know-how and you are experiencing any level of fear, concerns, anxiety, or worry, think about different ways to prioritize your mental health, whether by conventional practices or alternative practices, whatever your preference is. If you've had race-related experiences, share those with providers. That's what we want patients to do, especially if you're a patient who's come from a different provider to a new provider and you haven't told your new provider what happened with the last provider. We're not asking new providers to fix it or to be perfect, but we definitely want to set a standard of expectation as to what I feel is unacceptable to happen moving forward based off of a previous experience. This is another one that I just kind of got in feedback from African American women, which is just teaching your birthing partners how to advocate on your behalf. I'm fortunate enough, my mother is a registered nurse. She's also a midwife. As COVID was happening and there was this conversation about me going into labor and my significant other not being there, my mom started the conversation because she normally would have been there to help advocate for both of us. So she started the conversation with him and with myself on the things that we could do to advocate for our voices, advocate for ourselves using our voices. So thinking about teaching your birthing partner how to advocate for you if they see something they feel is biased or based off an experience. How do we teach that significant other or our birthing partner to speak up on our behalf, knowing full well that a lot of women during the childbirthing process specifically will say that I lost my voice. There were things that I wanted to say, but we know it's a painful experience, and I wasn't able to articulate myself. Another thing that we can take into consideration for patients, think about ways to add a racial bias intervention page to your birth plan. And I've done this with a few patients and clients before, and what that really looks like is a 3 to 6 point strategy that outlines what you as a patient will do and then what you expect of your provider, whether it's your OBGYN and even your hospital. What do I expect for them to do, and what will I do if racial bias presents itself during my birthing process? And you can talk directly with your providers, or even just asking the hospital, what are their protocols? What are the things that can be done if I feel as though I'm having an experience that is influenced by racial bias? As patients, it's so important to continue to evaluate your level of trust in your provider. As a mental health care provider, my clients are constantly in a position of vulnerability. If you are in maternal health care, as a patient, you're constantly in a position of vulnerability. You're entrusting your life, your child's life to your provider. If you start to feel as though you don't trust your provider, you really need to think about different ways to evaluate and what is the appropriate, realistic response to the fact that you're losing trust in your provider. Is it something that can be rectified, or do we need to think about a different provider? And then last but not least, do not be afraid to speak up. If you think something is racially motivated, I encourage my clients to ask me clarifying questions. You know, Dr. Rose, you just did something that I'm not sure where that came from, but in my perception and my experience of you just there, I thought that that was a biased behavior. Can you explain it further to me? Don't be afraid to speak up. I think, unfortunately, with communities of color, especially the African American community, we know that there's a long embedded history of intergenerational historical trauma. How we think about how trauma presents in 2020 is that we all come from these cultures that are heavily embedded in continued silence, right? So this idea that we come from these cultures that celebrate silence, keeping things silent, not speaking up for yourselves. When it comes to your life and the recognition that we're in a maternal mortality healthcare crisis, patients have to think about different ways to be able to speak up for themselves. And then last but not least, I always highly recommend documenting any negative experience that you have, whether you ask for it to be documented as a part of your file or you document it for yourself and keeping rigorous notes of your experiences with different providers. So let's talk about things that providers can do to help reduce implicit racial bias. First and foremost, you need to identify your implicit biases and what they are and what they look like. And one of the ways that you can do this is you can take the race-based implicit association test. And I highly recommend taking it regularly. By regularly, it's once or twice a year. So every 6 months or just every 12 months. The implicit association test is actually administered by Harvard University. You can go online and access it from there. It's a free tool that you can use at your leisure. And all you have to do is just Google Project Implicit. Harvard University still currently retains the highest body of research on implicit biases and implicit association. And just to tell you a little bit about the test, what the test is going to do is basically it's going to reveal your preference regarding positive and negative evaluations of white and or Black community. Unfortunately, the race association test does not expand to other communities, i.e. the Asian community or the Hispanic community in testing, but it shows whether you have a preference for darker complexion individuals or lighter complexion individuals. When you take the test, it takes about 10 to 20 minutes. What it's going to reveal to you is your preference. So it will say that you have a preference for white and or Caucasian individuals, or you have a preference for Black and or African American individuals. I want to say this, that that's not the problem. We're not concerned about your preference. Preference is normal. It may imply where you feel safe, where you feel comfortable as a provider, or what you are familiar with. The thing that we want to pay attention to is when the implicit association test communicates to us the strength of our preference. So is my preference strong? Is it moderate? Is it weak? And as a provider, you want to be somewhere between weak and moderate. You do not want a strong association. That strong association is really where we see the unconscious racial biases that tend to result in negative encounters or experiences for other people. So as a provider, I actually take this, the implicit association test, I take it twice a year. I take it because I have a high portion of patients who identify as LGBTQ+. I am a heterosexual female. I do not have the same experiences as them. So I try to use it to hold myself accountable, just to see where my preferences are and if I have any biases. I also share my results with any patients or clients who ask for information, or they ask to see my results and what that looks like. If you are finding yourself taking the test and you take the implicit association test and it shows that you have a strong preference, I recommend taking it again in 6 months. And in the interim of that 6 months, you should be practicing different debiasing strategies, which we're going to go through. Another great way to reduce implicit racial bias is to go over patient education and literature on implicit racial bias. So this is actually something that I provide within my practice. So I'm going to share a document with you all. Let me see if I can do a new share. Okay. Okay, so I'm not sure how clear you can see that, but this is my handout and my client literature that I give on implicit bias in mental health care, because I'm in mental health care. So my clients get an overview of what it's like to be in a part of my private practice. I explain what implicit bias is to them, why implicit bias matters. I talk to them about implicit racial bias, and then I talk to them about implicit bias in mental health care. And then I give them pose this question: how will I know when I encounter implicit bias? And it goes over some of the feelings, what it looks like. And then lastly, I talk about the things that I am doing individually and as a private practitioner, mental health care provider, to combat and confront implicit bias, which even go down to one of the smaller things here, which it says I'm raising my children to embrace diversity, equality, and fairness for all. I'm really holding myself accountable. If they're not comfortable with what it is that I'm doing to confront implicit bias, or they have an experience that they don't know what to do, I also go over what they can do if they encounter implicit bias within my practice, which includes different ways to ask me clarifying questions, to communicate with me. And at the very bottom, I hold myself accountable at the fullest measure, which is just reminding them that I am licensed, where my license is parked with. I report to the California Department of Consumer Affairs, California Board of Behavioral Sciences, the California Board of Psychology, and these are all places and options that they have to go and file a complaint should they need to. But I will tell you, in 10 years of practicing, I've never had that issue. And then I'm going to go back to just kind of sharing where we were. So that's a form of client literature that I highly recommend. I created that client literature myself. It is something that I provide in consultation. If anybody is interested and you want to get one for your organization, my email and my website are located at the end of this training, and you'll be able to reach out to me. I do charge a fee for a service. but it is something that I can get you access to, and I am able to curtail it to whatever the needs are, because obviously mine relates to mental health care versus maternal health care. Think about discussing maternal mortality and implicit racial bias with patients of color. So this is something that I think about our society today, is that we are really infringed in this idea or this fear about the power of suggestion. We're not talking about race because there is a fear in Western society that by saying it, we're going to implant it in a patient's mind. So let's call a spade a spade. Your patients are already thinking about it. You want to have a conversation, and sometimes the conversation can start off with the client literature. Hey, take a look at this literature. Here's my email. Get back to me. Let me know some of your thoughts or anything that you want to know from me. Or just asking about fears and concerns, and really prioritizing that as a way of combating this maternal mortality healthcare crisis. Think about partnering with maternal mental health care providers. I am a big fan of Postpartum Support International, as well as Return to Zero Hope. And with PSI, Postpartum Support International, they have a subset that is Perinatal Mental Health Alliance for Women of Color. And it also gives you like a whole list of providers that specialize in maternal mental health care for clients, specifically patients of color. So think about ways to partner or to add that to your referral list, or to even just give that as a resource for people that are communicating to you that they may need that resource. Or even for the ones that don't communicate they need that resource, we want to think about ways to make it readily available to them should something change. Include a racial bias intervention strategy in birth plans. I said this for patients, this goes for providers as well. If you have a standardized birth plan that you have within your provider practice, wherever it is that you're operating, think about offering an additional plan and strategy. What that looks like is really going to depend on the mastery knowledge that you have based off of your discipline. I am not an MD, I am not a midwife, I am not a nurse practitioner, I am not an MFM, maternal fetal medicine doctor, right? You have knowledge in terms of how you think or you compare your mastery knowledge of your craft, your field, together with the things that could be done to intervene if a patient reports that they're experiencing racial bias in their birthing process, or even just in their prenatal care with you or their postnatal care, right? Then we want to teach patients how to self-advocate in the face of racial bias. So what does that look like? Having a mother who is trained as a midwife, she taught me very quickly when I was pregnant with my first son, when you go there, let them all know I'm a midwife. And I didn't really know why, but after a while, I noticed that the nurses would always put it on my chart and on my board as they were changing shifts. Mother is a midwife. And I think for her was her way of saying that they're going to know not to try and get things over on you, because you're probably communicating a lot of things with me. And that's a great way to self-advocate for yourself. As my mom is a nurse too, she also tells me if you have a problem in the hospital, call the charge nurse. To each his own, but it's not the worst thing to consider, especially when we're thinking that racial bias can really end in a situation where we're talking about loss of life. When implicit racial bias is reported by a patient, I think this is one of the most important pieces. Believe them. Sometimes what can happen for providers is you're going to step back into a space that becomes very self-defensive or defensive in nature, and thinking that somebody has made an accusation that you are racist or prejudiced. But like I explained before, if you are adopting or you are understanding the beliefs that we all have biases, they're there, okay? And to have a bias, you have to have prejudices. So we all have prejudices. What a patient may be communicating to you is how they are experiencing your unconscious or unaware biases or prejudice. So believing them is so big. When we were talking about the patient factor, we discussed the simple fact that being able to speak up and advocate for themselves, especially within the African American community, can be so difficult and so hard. So when a person finally does catch their voice or they find their voice, we definitely want some form of affirmation or alignment or something that says, I hear you, I see you, I believe that you have had that experience of me. What can we do moving forward? And then be willing to champion and advocate on behalf of patients. I'll be honest, my maternal health care providers are absolutely amazing. One of the things that I love about them, I've now moved some 30 plus miles away from their office, and I still travel back there and intend to travel back there for additional pregnancies in my future, because of the ways in which I've experienced my maternal health care providers of championing and advocating for me. While I experienced my last pregnancy as a stillbirth, one of the things that I can look back, having evaluated my entire experience, were that these amazing healthcare providers did everything within their power to provide me with assistance and to also support me in getting the best outcome possible, considering the scenario. And then I think it's also important to identify yourself as an ally for racial equality in maternal health care. What that looks like really depends on you and your level of comfortability. But here's what I'm going to say. During civil rights, it was a really big priority for African Americans specifically to be mindful of where it was that they went into and to look for organizations, buildings, businesses that identified themselves as being friendly to the African American community. Yes, we are far removed in years from the civil rights movement. Unfortunately, some of the same behaviors and precedences are continuing to perpetuate. And if you are able to identify yourself in whatever way that is as an ally for racial equality in maternal health care, that may open up the dialogue with some of your patients regarding how it is that we can combat this within your prenatal and then your postpartum experience with me as your provider. I know for myself at Pepperdine University, one of the things that we're incorporating now into our syllabuses is like an anti-racist statement. So if it's something that you want to communicate like that or verbally, I highly recommend just letting people know what you are allied with. Other things for providers to take into consideration, attending regular racial bias trainings and events. Whatever that looks like in terms of the ones that are being offered for you. The simple fact that you are all here today speaks volumes for your intentions to do something to help combat this crisis that we're currently encountering. And to advocate on behalf of communities of color, African American community who are just being disproportionately affected. So why I specifically say attend regular racial bias trainings is because what we know is that the research is continuing to emerge, right? So every year we should expect new information, new debiasing strategies, new things that are based off of new principles that we've been able to assert, or areas where we've had success. That is what we want you to be on the lookout for. If your organization does not require it, if you're just an individual practicing provider and you're thinking about ways to better yourself and to improve yourself on behalf of your patients, then attending regular racial bias trainings and events is going to be important. And then we also want to think about different ways to professionally and then personally seek out diversity. And when we're doing this, we are really doing this as a way to shatter stereotypes by using proximity. So professionally, what that looks like in terms of your colleagues interacting and just kind of being clued into some of the information that they have based off their experiences, and then personally seeking out diversity, whether it's in your friendship groups, your interactions, and not, I'm going to say this very politely, and not just in the places that you go to eat or to interact on a social level, right? So we definitely, like I said, want to think about ways to shatter stereotypes. And when we shatter stereotypes, we normally do that through proximity. And then we're also going to practice perspective taking and decentering. Specifically, decentering allows us to kind of step outside of our own lens and see the world through the eyes of others, while we're able to actively kind of like connect with their mental states and their subjective experience. So it's really a way of increasing your empathetic value and your understanding. Think about enlisting a professional accountability partner. I have an accountability partner as a private practitioner. I ride solo dolo. There is no manager that anybody can go to and complain about me. But I do have a professional accountability partner who holds me accountable for things that can present itself in the form of like microaggressions, any biases. I also give the information for my accountability partner on that little brochure for implicit bias. I give it to my patients in the event that a patient is really struggling to have a conversation with me about something they experience. I want them to know that there is somebody in my life who professionally holds me accountable and can kind of have conversations with me to help improve my perspectives or expand my opinions and things that are expressed in my daily professional life. And then we also want to openly discuss experiences of racial bias with you and other healthcare providers. And then always think about engaging in extensive reading about racial biases, prejudice, and structural inequality. I do have a reading list that will be accompanying this slideshow, and it will be provided to you via email when you get the link to this webinar. And then hold yourself and others accountable, whether that is in a professional setting or in private settings. What we're trying to do is bring the unconscious to a conscious state, and by holding others and yourself accountable every time something shows up or when an unconscious bias surfaces, we can bring it into automatic thinking that is something that we see as wholly unacceptable and not something that we embrace. We want to think about embracing diversity with children and family. What that really does is just helps us to normalize this shared value of diversity, equality, and fairness within both our macro and our micro systems. And then last but not least, for providers, think about ways of extending postpartum visits for patients of color. If the CDC recognizes the maternal mortality rate as being calculated at anywhere within the first year, or death that occurs anywhere within the first year after childbirth, then it can be really concerning when you look at the fact that on average during the prenatal term, an individual can have anywhere in excess of 12, 15 visits, but postpartum are 2 visits. And that's on average. So knowing that we are currently in this crisis that is disproportionately affecting communities of color, we want to think about different ways that we can extend postpartum visits in a way that we see as appropriate and reflective of the mastery knowledge that we have about our discipline. And then here goes for organizations. So when we're thinking organizations, I'm going to be speaking more. Sometimes these can be nonprofits. This can also be hospitals, but they're really the organizations that tend to be in charge of the systemic level of how implicit racial bias is showing up. So for organizations, I think it's important for them to think about ways to strengthen and support existing maternal health programs. We want to think of ways to offer African American women more tools to navigate their healthcare system. Sometimes the way in which navigation or tools to navigate the healthcare system are offered are under the presumption that we are all of the same consensus, awareness, and exposure to how to deal with a system, and the reality is that's just not true. With communities of color, we know that they have less exposure to how they can effectively navigate their healthcare system, which is why we want to then offer more tools. What those tools look like can be different for different organizations, regular orientations, meetings, online trainings, webinars, YouTube videos, dissemination of materials, information, whatever it is that they can bring to the table. Organizations need to think of ways to train providers to address racism and build a more diverse healthcare workforce. If the study produced by George Mason University highlights that African American infants are more likely to survive when they are in the care of an African American doctor, I think that in itself really does speak volumes for how much we need to diversify our workforce to try and decrease the loss of life that may be occurring unnecessarily. I think it's important to create culturally competent assessments for mothers and infants. And some of the assessments that we see within organizations are even just surveying assessments. I can't remember the last time I left an emergency room or a doctor or an emergency visit, labor and delivery, and I was ever asked the question, do you feel that the race played a role in any experience that you've had during your time here at this hospital with this organization. The information is not being compiled, it's not being collected, and it's also not being assessed for. And we know that it does play a role in healthcare outcomes. Organizations do need to work towards eliminating barriers for accessing quality maternal health services. For myself, I had recently spoken to a patient who's communicated to me a few years ago that they had spent some 14 hours in an emergency room waiting to be seen. I remember asking them, well, where did you go? And they referenced a hospital that was in their community, which was a low income, lower SES community. And I brought it to their attention, hey, next time you have a problem, go to this hospital. It was my local hospital in a different side of town. But I knew that they worked through their emergency room a lot quicker, and on average over a span of about 7 years, I only ever spent at maximum 2 hours waiting versus 12 hours. So when I say eliminating barriers to accessing quality maternal health, we want to make sure that individuals are able to go to hospitals, organizations that may be outside of their community, because some of those hospitals are seen to guarantee more quality maternal health services. We want to enhance support for families before and after birth. So speaking about that statistic that measures maternal mortality at death that occurs within that first year after childbirth. We want to fund community-based maternal health education initiatives. I'm just going to speak specifically on a program that I found out about years ago when I was serving as an executive director for a nonprofit in Inglewood. The organization was called Beautiful Beginnings for Black Babies. And they were doing a lot to minimize the barrier between women of color and just their education on maternal health care, breastfeeding, infant care, things of that nature. They were doing great work, but the reality was they were a nonprofit that wasn't being well funded. And unfortunately, they ended up having to close their doors despite all the great work that they were doing. So we want to make sure that organizations are doing their part to kind of tie into community-based education initiatives. Mandate and fund fetal, infant, and maternal mortality review committees. If a death occurs, an organization needs to have some level of accountability or committee that is in a position to kind of review some of that information. And then we also want to think about requiring implicit racial bias trainings. I mean, we all have to do the sexual harassment trainings. We all have to do other trainings that our organizations require us to do. Implicit racial bias, specifically within maternal health care, hospitals, and so forth, should be something that's mandatory. And unfortunately, at the moment, it's not. Organizations need to think of ways to provide maternal health care advocacy workshops. So I know during my pregnancy experience, one of the things that came up was the hospital that I was going to was providing great workshops. I got infant CPR, preparation for childbirth. I got a hospital visit and a tour of the maternity ward. I got things that helped me prepare for labor. But what about advocacy workshops and teaching some of these patients how to advocate for themselves? And then we want organizations to begin separating implicit bias from DEI programs. So DEI, diversity, equity, and inclusion programs. And I'll tell you why. Diversity, equity, and inclusion programs, especially for those of you in the corporate world, you may be in a position where they're now starting to mandate them. But these programs have been in effect for some excess of like 20 years. After 20 years, we're now compiling the data, which shows that they're actually very ineffective. They create the discussion, they actually do not create or provide the tools for the discussion to then lead to changes within an organization that are reflective of diversity, equity, and inclusion. And unfortunately, DEI programs are a great umbrella that organizations will throw everything that is racial, that is diverse-based, that has anything. We just throw it all in there with DEI programs, and realistically, we need to think about ways to separate implicit bias, especially racial bias, because of the detrimental effects that it's having, and the fact that it's associated with DEI programs means that the conversation can be kept in a place that's ineffective. We want to create standardized implicit bias protocols. So anytime racial bias is alerted, an organization should have an immediate protocol that's put into place, whether that is all the staff on board have to start writing reports, word for word. We get witness accounts from the patient involved. What are the things that are immediate protocols once implicit bias or racial bias is brought to the attention of the organization? As a consultant, I do work with some nonprofits to help them create boards, and advisory boards are probably some of my favorites because advisory boards are normally neutral. So you can have somebody who's a school teacher, somebody who identifies as a mother, somebody with some medical experience, somebody who works at the donut counter within the community, somebody who is a teacher, but they all have investments within the community to try and improve any of the disparities that are going on. We want to address employee burnout and stress. So anytime employee burnout or stress occurs, as soon as that happens, and we know this happens a lot within the medical field, what that's going to force us to do is to fall back and rely on unconscious and automatic processes. When we begin to fall back and rely on those automatic and unconscious processes, that's where we're going to accidentally or unintentionally access implicit racial bias. So addressing employee burnout and stress is one of the things that we can do to support employees. And then we want to promote organizational diversity. I think it's important for organizations to ally themselves in the fight to reduce racial bias, and they can do that in different ways. One of the ways that was suggested in a previous training provided by Return to Zero Hope was this idea of creating a pledge within an organization to improve maternal mortality. You can have everybody from the receptionist to the labor and delivery nurses to the midwives. Everybody should sign this pledge that we are all dedicated to improving maternal mortality rate in this country. Celebrate employee differences, and we want to ensure quality assurance for maternal health. And then last but not least, we're going to contribute to emerging research. One of the reasons that we are even in a maternal mortality healthcare crisis is because the research for some excess of like 20 years was not being adequately or effectively collected in a way that there were things that were going on and nobody actually knew because the data wasn't being collected. So organizations do need to prioritize contributing to emerging research, providing data, statistics to individuals or organizations that do the program evaluations or to program evaluators, or to even administer their own program evaluations so that they can see where they are, keep it in a state of awareness, and then kind of go from there to help reduce implicit racial bias and improve that maternal mortality rate. So last but not least, this is kind of where I'm going to leave you guys, and we'll go into a question portion of this with debiasing maternal healthcare. This goes for providers and patients alike. If you feel something, please say something. I'm going to give you the specific story. In 2016, there was a Nevada-based maternal healthcare provider, OBGYN, who arrived to the delivery of an African-American woman to her African-American daughter, and he arrived to the birthing process inebriated. He was very boastful about the fact he'd just been to the bar, he took shots, and during this whole process, the mother, and she was there in the room with her birthing partner, who was her mother, could smell alcohol on his breath. The nurses knew there was a conversation and going back and forth between him and the nurse. I just took shots. I was at the bar. And her child was born with a birth defect. In pursuit of justice for her and her child, she was fortunate enough that when her mother noticed something was wrong with the doctor, she began to record the doctor, and they had all this footage of his behavior while he was intoxicated and trying to help with the delivery of her child. Now, as crazy as that scenario is, and we know that that doesn't happen often, unfortunately, there are some really rotten apples out there, but that is not to speak to everybody that's here. But what really struck me about this case was a lot of the feedback and the backlash that the mother got when the question was posed to her, why didn't you say something? Why didn't you stop him? Why didn't you do something? And I believe her response was that I didn't want me saying something to have a negative impact on my birthing experience and negatively impact my child. Unfortunately, not saying something ended up with the exact same result that she was trying to avoid. So here's the reality when we're thinking about conversations of race, racial bias, or debiasing in maternal health care. The reality is our biggest fear, whether provider or patient, is the fear of what if I am wrong? What if I felt something that I think is racially based, but I am wrong, right? I kind of want to flip and challenge everybody here to turn that upside down and ask yourself the question, what if you are right, right? If you are wrong, bruised egos, a little bit of pride. If you are wrong, if you are right in this scenario, that race is playing a role in my interaction with another individual who is contributing to my healthcare, the consequence of that could be loss of life for a mother and infant, and that's what we want to pay attention to. Don't worry, the saying goes, pride cometh before the fall. We can put our pride aside and just ask, if you feel something, say something in whatever way that is. That way we can minimize the possibility of us contributing or being a contributing factor to the loss of somebody else's life. All right, guys, so we are going to go into questions. I know we are close to time. Okay.
Hi there.
Hi.
Thank you. Okay, I have a lot of questions. Well, I mean, I'm sure that more will come. So we'll go through this. We'll try to answer, if you could answer somewhat quickly, and if we need more follow-up, we can do that. So the first one is, what are your thoughts on adding being African American as a risk factor in a pregnancy with respect to mortality rates?
Okay. Well, I'll tell you, as an African American woman, my thoughts are that it's extremely concerning. I've only had one maternal health care provider as a team. It's a female doctor and a male doctor. And more recently, during my birthing process, for my last pregnancy, my husband changed jobs and changed insurance companies, and the insurance company told me that my primary care provider or my maternal health care provider was not registered with them. I cried for 3 days. And when I was thinking to myself, well, what was causing me this emotional state? It's because I had a fear if I had any other doctor, I was going to die. So if I'm being honest, what do I think about it? It's extremely concerning. It is scary, but I don't necessarily think that it's something that we cannot work to improve, especially as we're starting the dialogue and the conversation. Hope that answers your question.
The next question is, can you talk more about, in your presentation, about needing to rule in racial bias on behalf of someone you're talking with until you can rule it out?
Right. So I kind of gave that example from the patient perspective or the individual. So what it is, and I'm going to guess a large number of us here are women. There may be some guys. I apologize. But think about it sometimes and relate it to your experience as a woman, right? When somebody treats you in a way, or you go to your mechanic and your mechanic gives you this quote and you're like, that's ridiculous. Your question becomes, is this because I'm a woman, or is this because this is the actual price? The simple fact that you cannot rule out your gender as being the cause for why you're getting this exorbitant quote causes you to have to consider it. It's not something that you can let go. If you do let it go unnecessarily, you might find yourself coming back to this provider who can continue to cause you financial harm. That's just a simple example of that. For those of us who identify as individuals of color, it's a constant thought. If I walk into a store and somebody doesn't say hello to me, I do have to take into consideration, is it because you're busy, you're having a bad day, you didn't see me, or is it because of the color of my skin and that there are some prejudices and biases in play? I am clear or understanding that not everybody sees me as equal based on the color of my skin, and people have their own prejudices that assert themselves differently. So that's what happens for individuals of color on a day-to-day basis. We have to ask ourselves, is race playing a role in how we are being treated?
Thank you. Okay, the next question is regarding your advice about speaking up. I think this is about a patient speaking up. What about the real risk of patients and families of color who seem or are labeled as non-compliant and then further dismissed by the care team, and this is potentially leading to worse outcomes?
Definitely. Unfortunately, we do see that happening. So as an African-American woman, one of the experiences that I am very aware of is this idea of being labeled the angry Black woman. If you are a white woman who's aggressive, you're considered shrill. If you're a Black woman who can be assertive, you're considered aggressive or angry. So thinking in context with that and the way in which we're seeing, there's a whole reality to take into account that there's a possibility no matter what you do, you're going to be seen as non-compliant. You could be as assertive, compliant, you can say what you would like to say, and people are still going to treat you in a way that is, their behavior towards you is not determined by your level of compliance. It is determined in this situation by your race. And we want to make sure that we're keeping the conversation in the arena that it deserves to be in. When that does occur and speaking up, I like to give people the opportunity to reveal themselves. Worst case scenario, somebody is going to confirm the things that you were already feeling. Now it's like, let me contact my insurance company, let me find out my options. I want you to be mindful that there are insurance companies who provide advocates for you on your behalf that will discuss with your care team or find you a different care team. But it now places me in a position to make an affirmed decision about my continued care, hopefully with a different team. And continue to ask for more individuals. If you're in a hospital setting, if you're with just a simple provider in their office setting, ask for other options, other alternatives, and start looking at those options once having it confirmed. But don't let the idea of being seen as compliant or non-compliant allow you to place yourself in a position that could jeopardize your health or your well-being or your life.
Okay, thank you. Okay, another question is, what would you suggest is the best way to facilitate conversations regarding race and bias towards BIPOC for organizations with predominantly white people and have limited funds or resources for trainings?
So what is a way to facilitate that conversation?
Yeah, whoever asked this question, would you be able to clarify a little bit more? And while you're doing that, I'm going to go down and ask a couple more questions. So someone is a postpartum RN. She's found that informed patients, both Black and white, are coming in after delivery and absolutely petrified, terrified about postpartum hemorrhage or dying after the childbirth process. Acknowledging that their fears are not crazy, but also knowing that we're working to keep them safe. What's the best way to reassure them without dismissing their concerns? And we want attention without high anxiety, so like they can celebrate their new family. So this isn't a case where an infant has not died.
Okay, all right. So yes, I think everything that you just said is a wonderful way to help affirm and support. Also understanding that this is where sometimes we want to consider a multidisciplinary approach to that postpartum portion as well. Are we getting this person in touch with other organizations and providers that can assist them with reduction of the anxiety? You're coming in as a postpartum nurse within your discipline to provide support. The things that you said that are life affirming, I am here to affirm life as you're going through this process. And that is our goal. It's definitely the best step to take and the first thing to make clear with an individual. I think the next step becomes like, how do we get you access to resources that can help minimize in areas that I may not have expertise? But going back to what I said previously, we want to believe them and just saying you're not going crazy. You are right in thinking about that. And then giving them, which I think a lot of postpartum RNs do, which is just that list of, if you have any of these symptoms, here's what you need to do. My maternal health care providers are great. I know they don't do this with all their patients, but in serious situations, which mine was included, I had them on speed dial, like text message. What are ways that they can access healthcare or your participation in their healthcare outcomes immediately, versus sometimes we go to an operating system who has to get a hold of the doctor, who has to go different ways. So reassurance is going to be of high quality and importance in that situation.
Okay. Okay. So we're past time. I'm just acknowledging that right now. I'm going to make a couple comments, and then however long Dr. Rose can stay on, we might stay on a few more minutes to answer some questions. But I just want to first thank everybody for being here and for being, like dedicating time to this important topic. Return to Zero Hope is a nonprofit organization. And so if you feel so inclined to make a donation for listening to this information, that you got something out of it, we'd be grateful. And I'll send a link out for that. We also have a directory on the Return to Zero website, which is for individual support, which is therapy or psychiatry. We have support groups and support organizations, and we have national organizations. So if you, I'll include that in the email as well, but if there's a form you can fill out to be included on there, and there's no cost to that. And we also have a luminary program, which is for those of you who are interested in being ambassadors for pregnancy and infant loss. So there's different ways to be involved, which I'll send out in the email. So I just want to thank you all for being here. If you need to go, we're over time and you can go. I'll ask her a couple more questions that have come in, and then we can kind of just wrap up, and I'll include Dr. Rose's email as well, that you can reach out to her. So one thing is support groups for perinatal loss. So I know Return to Zero Hope has support group programs, like a closed group that we offer. There we have a miscarriage group. We have a more like stillbirth infant loss. PSI also has a weekly group that they offer. So that is what's available there. A number of you have asked about the birth plan template. And I will talk to Dr. Rose. I know there's been a lot of questions about what we're going to send out and available. So I will really talk with her after this. And when I send the recording out, along with the resources and the reading list, we'll just let you know kind of whether it's there or not. I'll make it pretty clear on what we're doing. Let me just see if there's any other questions in here. I mean, there's a lot of information, but mostly thank you, Dr. Rose.
You're welcome.
Yeah, and I'm going to go back to the anonymous question about just like conversations. I think what they're asking is conversations around race and bias towards persons of color, right? In an organization that's predominantly white, and we have limited funds for resources of trade. Okay, so that's just my organization, right? Like, we're predominantly white. We don't have a lot of money. What can we do?
I think you can come or start the conversation from a position of humility. I come from that, I think it's a Socrates quote, you know everything when you know nothing at all. So approaching your patients of color and being honest and saying that we are a predominantly white organization. We know that there is a disparity, and we're trying to bridge that gap. Here are some of the ways that we are trying to, but we also would like to be in partnership moving forward with some measures that we can implement or that you feel would be effective. So allowing patients in that situation to inform some of your decisions, your practices, And then if you are a smaller organization and you want to check for your organization's biases, I highly recommend taking the implicit association test. See where you land and where you scale, and what your results look like, and have some open discussions about that, that there are preferences that are in play and how does that show up. In situations where you can practice, and when I go and I do in-person trainings on implicit racial bias or implicit bias, I do actually do rehearsals and role play activities where we play out, what if somebody says to you, hey, I think you're racist, or I think your decision or your behavior towards me was racially motivated. What are some ways in which we can respond, and to get that experience, and then just always move forward from a perspective of learning, understanding, and knowing you're not going to get it perfect, you're not going to get it right, but your humble in your approach will help to inform you moving forward. So I hope that answers the question.
Okay. I think we're going to wrap it up today. Thank you again so much for being here, Dr. Rose, and for all of you for being here.
Thank you all.
Yeah, thank you. And we will follow up soon. If not tonight, I'll do it tomorrow, and with a recording and other information. So thank you, everybody.
Perfect. Take care.